Okay, hi everybody. This is Brother Wolf. This is HS 375, and today we have Group 6 presenting on managing hospice care organizations. And I will turn the time over to them. You may start whenever you're ready.
Okay. So
Okay, so
on this
hospice,
first one, there's a volume thing. I don't know if that'll play the same through the presentation, but it should work.
okay. So hospice defined. Hospice is a comprehensive program. It is a concept of care, not necessarily a place of care. Hospice affirms life. Dying is a normal process. Hospice neither hastens nor postpones death. Hospice emphasizes palliative care rather than curative treatment. Hospice emphasizes quality of life rather than quantity of life. And the patient and family needs are both included in the care plan. Next. Hospice care is focusing on caring, not curing. In most cases, care is provided in the patient's home. Hospice care also is provided in freestanding hospice centers, hospitals, and nursing homes and other long-term care facilities. Hospice services are available to patients of any age, religion, race, or illness. And then what services are provided under hospice? There is a large scope, but there is an interdisciplinary hospice team. They manage patient symptoms and pain. They assist the patient with emotional, psychosocial, and spiritual aspects of dying. They provide needed drugs, medical supplies, and equipment. They coach the family on how to care for the patient. They deliver special services like speech and physical therapy when needed. They make short-term inpatient care available when pain or symptoms become too difficult to manage at home or the caregiver needs respite time. And they provide bereavement care and counseling to surviving family and friends. Next.
Okay, so palliative care improves the quality of life for the patients and families of patients with life-ending illnesses. It is aimed solely at treatment of symptoms associated with life-threatening illnesses. And I added some examples in because I have actually done this with my mother-in-law as we watched her pass away from cancer. And part of that is to provide morphine to control their pain. And it also helps with arranging for their appropriate religious counsels as they come to the end for the patient with them and their family. Next.
On the history of hospice care, the term hospice was first used in medieval times. It was a shelter for people who were tired or sick and who needed to take a rest while they were traveling. And in 1948, physician Dame Cicely Saunders started working with the terminally ill and later created the first modern hospice in London called St. Christopher's Hospice in 1967. The National Hospice and Palliative Care Organization was founded in 1978 as the National Hospice Organization. The organization did later change its name in February 2000 to include the palliative care. Next.
Okay, reimbursement of hospice care. Hospice is covered 100% by Medicare and Medicaid. In addition, services may be paid by Veterans Administration hospice benefit and some commercial insurances. Hospice coverage includes medications, medical equipment, and supplies related to the terminal illness. Under Medicare law, no person may be refused hospice care due to inability to pay. Each hospice must have a financial specialist on staff to answer questions about receiving financial assistance. Next. Reimbursement by Medicare. Coverage for hospice care falls under traditional Parts A and B of Medicare. Medicare Advantage plans do not cover hospice care. Hospice care is an elected benefit covered under Part A of Medicare for patients who meet all the following requirements. The individual is eligible for Part A. The individual is certified as having a terminal illness with a medical prognosis of 6 months or less to live if the illness runs its normal course. the individual receives care from a Medicare-approved hospice program, and the individual signs a statement indicating that he or she elects the hospice benefit and waives all other rights to Medicare payment for services related to the treatment of the terminal prognosis. Medicare will continue to pay for covered benefits for services that are unrelated to the terminal prognosis. Next. Reimbursement by Medicaid. Medicaid participants, those who are eligible, can receive hospice care when they are terminally ill. To be eligible for hospice care under Medicaid, you must be terminally ill as certified by a physician. You must choose the hospice benefit by completing and signing an election form. You must agree to receive care to manage your symptoms and make you comfortable, but give up give up care to cure your illness unless you're younger than 21. Your physician must state that you have a reduced life expectancy as defined by your state each time he or she certifies your eligibility. States are required to offer hospice benefits for at least 210 days, which is approximately 7 months, and the states may divide those into 3 time periods however they like, usually 2 90-day time periods and 1 30-day time period. And although the states aren't required to adopt the Medicare guidelines, most do in order to coordinate care. Next. Reimbursement by commercial insurance. Coverage varies by individual insurances. In the managed care market, those companies identify their network, and patients have to select a hospice within that network to receive coverage. Elderly nursing home residents on medical assistance may continue to receive room and board coverage for medical assistance while receiving hospice care. Next. Reimbursement by the Veterans Administration. Veterans can receive hospice care through the VA. The VA can purchase hospice services from community providers, including hospice care provided at home or an institution as an inpatient. Next. The role of CMS. CMS develops conditions of participation, known as COPS, for hospice and certifies eligibility in the Medicare system. CMS proposes and finalizes regulations that affect how hospice is reimbursed. This includes introducing new billing codes. Next. Role of Medicare and Medicaid in regulating hospice care. The state licenses hospice care, and Medicare certifies all hospice services. Of note, 3/4 of the 2.5 million people who die each year are ages 65 and older, making Medicare the largest insurer of health care provided during the last year of life. Roughly 1/4 of traditional Medicare spending for health care is for services provided for Medicare beneficiaries in the last year of life. And the high overall cost for health care received in the last year of life is not surprising, given that so many have multiple serious and complex conditions. Next.
Next is organizational structure. In doing research on this, there are a lot of different ways that a lot of different, I guess, organizations could go. I tried to find the most general so we could all follow along. So starting at the top, you have the medical director, followed by the executive director, who below them have the various directors of various departments within one of these locations. The example I used was off of, I believe this is called Green Country Hospice of Green Country. But basically, as you can see, a lot of emphasis and a lot of work looks like would appear to go through patient care. They're managing not just the RNs and everything under that department, but they would also be doing social workers, clinical coordinators, and LPNs, and that would be the most basic structure, the general structure. Again, this can vary depending on what the what the organization has and offers, but just a basic template to follow. Next, the main professional or the professional advocacy organization regarding hospice is the National Hospice and Palliative Care Organization. It's the largest nonprofit membership organization representing hospice and palliative care programs and professionals in the United States. And that really is no joke. I spent time Googling and trying to go to the 3rd or 4th page of a search to try to find something not associated with it, and somehow everything is associated with the National Hospice and Palliative Care Organization. or related to it, whether it's a different program associated with hospice care or palliative care at that point. Next. These are their missions. This is their mission: to lead and mobilize social change for improved care at the end of life. The vision is a world where individuals and families facing serious illness, death, and grief will experience the best that humankind can offer. And their stated values are: the NHPCO believes in service, engaging customers, respect, honoring others, excellence, exceeding expectations, collaboration, fostering partnerships, stewardship, managing resources. Next. Just a little bit more background. Some of this stuff, some of the information was already mentioned, so we'll just go over that really quickly. Headquartered in Alexandria, Virginia. It was originally founded in 1978 as the National Hospice Organization. The organization changed its name in February 2000 to include palliative care. They advocate through public and professional educational programs and materials to enhance understanding and availability of hospice and palliative care. Meetings and symposium on emerging issues. They advocate through providing technical information, technical or informational resources to its members, conducting research, monitoring congressional and regulatory activities, and working closely with other organizations that share an interest in end-of-life care. Next.
Okay, so I was able to meet with a manager of one of the hospice cares that's located in Rigby, Idaho. So Solace Hospice Care is what it's called. And the manager who I spoke with, her name is Kat. She had originally been a nurse within hospice care, and within the last 2 years switched to the managerial role. So I asked her about what some of the differences and challenges are in working with hospice care compared to that of traditional nursing care. And she said that being the manager, she spends more time in the office figuring out the schedules and everything, and so it's not as much family interaction, but she notices that she takes care of more of the families rather than just taking care of the patient, and that it's definitely more about comfort rather than healing, and that's sometimes really hard because you gain a connection with these different patients. And she mentioned that it's a lot harder when you can see their health declining because you've gained a connection with them and you know their family and you know their friends and you know who they are as a person rather than just a patient. She said that communication is really necessary because the patients are at home, they're not at a facility, so if someone is close to the end of their life, one of their nurses might have to spend more time at that house rather than going to the other locations and providing care. So they have to schedule that and they have to make sure that each of their patients are taken care of. And if you call in sick, a lot of the time it makes it a lot more difficult because there aren't just people who can take your shift because it is such a specified thing. Each patient has different needs and is at a different place within their end of life segment of time. And then some examples of hospice care organizations. I decided to focus mostly on southeastern Idaho because that covers a lot of the school base. There's Alliance Hospice Care, Hospice of Eastern Idaho, Idaho End of Life Coalition, and Solace Hospice, which is where Kat was working from. As I researched which organizations give hospice care, there are multiple in every state. There wasn't a single state that I could find that did not have hospice care. And so I think that's definitely something to make note of. And then these are the sources that we have. We have two different slides of sources. They are listed alphabetically A lot of it came from cms.gov as well as nhpco.org. And that's our presentation.
Excellent. Very well done. I think you guys covered the majority of things. Let me ask you a question, and it's kind of a subtle question, so if you don't really know, that's fine. But what's the difference? What would you guys describe the difference between the word hospice and palliative? I mean, there's some overlap there. There's some similarities, but what distinguishes those two words from each other?
Well, when you're doing the hospice part of it, when you get into hospice care, it's when a patient has started the decline and they need more time together and the family is preparing for that. As you get into the palliative care, it takes on a new level where you know the patient's within days of passing, and you are strictly there to give comfort, to keep them comfortable as they pass. And I think that it's just they run together so easily that you do think of them together, but they are two different sources of care given.
Okay. Any other thoughts?
I think that's true, but I think it's actually the palliative is earlier and hospice is closer to the end of life.
So can you have palliative care without hospice?
Yes.
Yes.
Yes,
They don't
you
have
can.
the diagnosis with the 6 months or less usually for palliative.
Right. Can you do palliative care for somebody who's not dying?
Yes.
Yes.
Yes, right? So palliative care, and this is kind of what I wanted to distinguish, palliative care can be for people who aren't going to die imminently, right? It could, palliative just means, literally it means to hide. So you're hiding the pain, or you're hiding the symptoms, you're diminishing symptoms, you're making patients comfortable, you're relieving pain and suffering. There's nothing inherent in the word palliative that means death. So it does not mean that you are dying. Whereas hospice implies that there's some sort of foreseeable, and again, no one has a crystal ball, so you can't really predict exactly, but the term hospice does imply that death is coming on at some point. Now, you could really get... Go ahead.
I was going to say, for an example, I'm part of a Crohn's and colitis group online, and one of my good friends is getting palliative care at home. She has with wound care and ostomy issues that she's having. She's at home on disability, and so the nurse comes in 3 times a week and helps her with dressing changes and helps her take care of the issues she's having. With
Right.
the expectation that in 6 months she'll be able to go back to work.
Yeah, so not everything in medicine is curative, right? So we have some success stories where somebody gets an infection, you give them antibiotics, and you're actually curing them. You're getting rid of that infection. Like you mentioned, Crohn's is a good example. There are some conditions and syndromes and diseases that are not curative, or you can't cure them. You treat the symptoms. You try to, and you can minimize and diminish a lot of these things, but you can't necessarily cure it. And so I just wanted to make that subtle distinction. We do lump them together for this presentation and for this group, that we're talking about hospice and palliative, because they really do go together frequently. It's just I did want to kind of point out those times that they're not exactly the same. So just kind of keep that in mind. You mentioned you guys did a great job on talking about the kind of the reimbursement models and methodologies, and you talked about Medicare and Medicaid and private pay. If you guys had to say, who is the largest payer for hospice services? If you had to pick just one. Did you come across that by chance?
Medicare.
Yeah, it is Medicare. And maybe you said that and I may have missed it, but just to kind of be clear for everybody, Medicare is by far the largest payer of hospice services in the country. And it kind of makes sense if you think about it, because most people qualify for Medicare when they're 65. Almost exclusively people over 65 are on Medicare. They may have supplemental and other insurance, but Medicare is a benefit that most people have earned by the time they're 65, and that's when most people, in those later years is when most people die, and the leading causes of death that we know of, many of them involve kind of a prolonged death, and so hospice is a way to is a major service of Medicare. And then we talked strictly about what somebody had to do to qualify for hospice. And so now these are kind of qualifying criteria set up by Medicare, right? Maybe a private payer is going to have different criteria. But since Medicare is such a major player in hospice services, we often default to their criteria, and you accurately stated a physician has to certify that the patient has 6 months or less to live. So if somebody is on hospice for 6 months and they're now in their 7th month, do they have to be kicked off hospice or taken off hospice? How does that work? Did you come across that at all?
It was mentioned in our presentation. It was mentioned in our presentation that it's if they have the prognosis that's 6 months or less. It doesn't say that they're going to just automatically kick them off just because they lived longer than they expected.
Perfect.
But there is a certification process that you sometimes have to go through to make sure that you have all the legalities and make sure that there's the help that you need.
Yeah, excellent. That's exactly right. Is that it's required to be put on hospice. You mentioned a bunch of other criteria as well. The patient has to elect it, and what they mean by that is, they're going to choose not to pursue any curative treatments. So they're giving up the rest of their Medicare benefits, so to speak. It doesn't mean that if they have a heart attack while they are on hospice for cancer that they don't get, cardiac treatment and those sorts of things. But it's you're absolutely right. People can live longer, and they do. It's a prognosis of 6 months or less. So excellent, good job. Yeah, and I think you guys really did a great job. You really covered a lot, so I don't really have much more to emphasize or notes, and I think the rest of the material in the course for next week covers some of the main points. So excellent work. I really appreciate your group doing this early. Most of the groups have been waiting until the last minute to present, so thank you for doing that. If somebody in the group would post the slides in next week's discussion board so that students can see the slides, and then as a group monitor that discussion board. Make sure that maybe students have questions about the presentation, so monitor it, engage the class, ask questions, answer their questions. Once I get the recording finalized, I'll post that link. And the other thing you can do, this is not required, but if you want to provide feedback on individual group members, you can send me a personal email. Don't copy or include anyone else. And if you don't send me anything, I'm going to assume that you felt like everyone contributed equally. I understand that group projects are sometimes not everyone's favorite, and sometimes some people carry more weight than others. And if you felt that that was a problem, then you can send me something privately, and you can say, I felt like everyone except X did a good job, or however you want to put it. But you don't have to do that if you don't want to. Any last minute questions or comments or other thoughts?
I'm good.
I'm good.
Okay.
Good.
Very good. Thank you all. Have a wonderful night, and we'll look forward to addressing this topic in next week's module. So thank you so much.
Thank you.
Thanks, everyone.
All right.